Okay, let's dive straight into this rapid-fire explainer on the surgical management of fluid and electrolyte disorders. We're doing clinical rounds today, so let's get right to the questions.
Section 1, Calcium and Potassium Crises. Jumping right into question 73. So, for an asymptomatic patient with a serum calcium level sitting right at 8.2 milligrams per deciliter, the correct answer is C, oral calcium supplements of 200 to 500 milligrams. You know, since this is asymptomatic, mild hypocalcemia falling precisely in that 8.0 to 8.8 range, it actually dictates a much more conservative approach. We just use standard oral calcium to gradually bring those homeostatic targets back up rather than rushing to aggressive IV therapy.
Moving on to question 74. Imagine a 30-year-old woman on her second post-operative day following a total thyroidectomy. She starts complaining of hand tingling, muscle cramps, and overt anxiety. So, what is the absolutely most appropriate initial management strategy here?
Well, the correct choice is D, continuous infusion of calcium gluconate. When you see active neuromuscular symptoms like tetany, you're looking at an acute emergency. This is usually caused by transient ischemia or, worst case, accidental parathyroid gland removal during surgery. This situation literally mandates immediate intravenous calcium gluconate, typically a 10% solution over 10 minutes. You've got to raise that extracellular calcium fast to prevent laryngospasm or even seizures. And here's a quick example for you. Most post-thyroidectomy hypocalcemia is totally transient.
Next up, question 75. Which of the following is a common cause of hypokalemia in surgical patients? The correct answer is C, vomiting. Prolonged vomiting or even continuous nasogastric suctioning is hands down the most common culprit for surgical potassium depletion. Now, while stomach fluid itself only has moderate potassium, the hypokalemia gets severely worsened by the kidney's secondary response. Because of the volume loss and metabolic alkalosis, the kidneys are practically forced to dump massive amounts of potassium just to conserve sodium. It's a vicious cycle.
Section 2, Fluid Resuscitation and Managing Alkalosis.
Let's look at question 76. For a patient dealing with gastric outlet obstruction and prolonged emesis, the correct initial management is B, infusion of isotonic saline with potassium supplementation. Think about it. This patient is losing massive amounts of hydrochloric acid. Your absolute first priority is restoring volume and correcting that chloride deficit with isotonic normal saline. That puts the brakes on the stimulus for aldosterone release. Then, once urine output is reestablished, you follow up with potassium chloride supplementation. The big exam pearl here? Avoid hypotonic fluids like 0.45% saline for sure. They lack the necessary sodium and chloride and can trigger dilutional hyponatremia.
Right into question 77. What if that dehydrated patient with gastric outlet obstruction completely fails to respond to your initial isotonic saline and potassium? The correct step is D, administration of 0.1 normal hydrochloric acid. If the systemic pH dangerously spikes past 7.55 or 7.60, you have to pivot to an aggressive central venous infusion of 0.1 normal hydrochloric acid to directly neutralize that excess circulating base. Now, for the exam pearl, ammonium chloride is an alternative, but it is strictly contraindicated if your patient has any hepatic insufficiency. Definitely keep that in mind.
Question 78 asks, what is the most common cause of hypokalemia overall? The answer is A, vomiting or diarrhea. Excessive gastrointestinal losses remain the single most common cause of potassium depletion across broad surgical populations. Those GI secretions are just packed with large amounts of potassium. And a key exam pearl to remember, losing these fluids leads to a normal anion gap metabolic acidosis paired directly with that hypokalemia.
Section 3, Critical Care, Lines, and Monitoring.
Okay, question 79. Regarding clinical indications for total parenteral nutrition, or TPN, the correct choice is E, a patient who has a major trauma following which return of bowel function is prolonged. You see, TPN is strictly reserved for cases where the gut literally cannot be utilized for over 5 to 7 days. The golden rule, and your exam pearl here, is that the enteral route absolutely must be attempted first if it's functional. TPN is only for when enteral feeding is straight up unsafe or strictly contraindicated.
Moving right along to question 80. What is the most frequent microscopic culprit behind catheter-related bloodstream infections?
The correct answer is C, Staphylococcus epidermidis. Since it's a normal skin commensal, it's responsible for nearly 31% of these infections. What it does is secrete an extracellular polysaccharide matrix, effectively shielding itself in a protective biofilm right on the prosthetic catheter surface. This lets it totally hide from host immune cells and standard antibiotics. Tricky, right? And here's a crucial exam pearl related to that. To definitively confirm line sepsis, blood cultures have to be drawn simultaneously from both the central line and a peripheral vein. For a true positive, the bacterial colony count from the central catheter blood sample must be at least 5 times higher than the sample drawn from the periphery at the exact same time.
Next, question 81, what is the earliest sign of line-related sepsis? The correct answer is B, tachypnea. You might be looking for traditional signs like a high-grade fever or leukocytosis, but those are often absent or blunted in critically ill or immunocompromised patients in the ICU. Tachypnea, which actually causes a mild respiratory alkalosis, is your earliest indicator. And another massive exam pearl. If a patient is cruising along on steady TPN, the sudden development of unexplained glucose intolerance or hyperglycemia is another highly reliable red flag of a developing systemic infection. On to question 82. What is the normal value of the FEV1 to FVC ratio? The answer is D, greater than or equal to 80%. A healthy adult with totally normal lung mechanics should maintain this ratio of forced expiratory volume in the first second compared to their total forced vital capacity.
To put that into a clinical perspective, obstructive lung diseases like COPD or asthma increase airway resistance. This prolongs exhalation and drops that ratio below 70%. Conversely, restrictive lung diseases, think pulmonary fibrosis, reduce total lung capacity. This actually lowers both values proportionally, which paradoxically leaves the ratio normal or even elevated above 80%.
And question 83, what is the most commonly used artery for cannulation and blood sampling? The answer is A, the radial artery. When you're drawing serial blood gases, the radial artery is the absolute go-to site. Why? Because of its incredibly superficial access right over the distal radius. Crucially, it also provides the safety net of collateral circulation supplied by the ulnar artery through the palmar arches. And your final exam pearl? Always verify that collateral ulnar patency beforehand by performing an Allen's test.
So, knowing how incredibly fast critically ill patients can decline, how will your heightened vigilance for subtle indicators, like sudden unexplained hyperglycemia or a creeping respiratory rate, change the way you catch and intercept sepsis tomorrow?